Assalamu alaikum. We will continue the discussion of the thoracic trauma. We reached to the slide of regarding the lung parenchymal injury. One of the injury types of the lung is the lung contusion, and it is the most common type of injury to the lung following blunt thoracic trauma. The underlying lung is often injured in moderate to severe blunt thoracic trauma. The area of contusion may be large, and this usually resolved spontaneously with time. But in cases of laceration of the lung tissue, there will be persistent air leak, which may require exploration by thoracotomy. You have to concentrate on this statement. It is important to prevent infection of the underlying lung by early mobilization of the patient and together with administration of prophylactic antibiotics, suctional drainage of any tracheobronchial secretion, together with physiotherapies. So any patient who undergoes thoracic trauma, the component of lung collapse, pain related to the trauma itself or the insertion of chest tube or subsequent thoracotomy, and the trauma to the lung parenchyma itself, all these factors collectively will result in decrease in the breathing capacity of the lung, so that secretions will be retained in the affected lung, and retention result in subsequent infection, and infection, if happened, usually difficult to control, result in lung damage. So we have to avoid these sequelae of lung infection by performing these steps of early mobilization, encouraging the patient to breathe deeply. Antibiotics should be administered, and suction of any retained secretion. Major airway injury. Injuries to the major bronchi are infrequent in surgical practice because the magnitude of trauma that cause the major bronchus to be injured is severe enough to cause damage of other organ, so that the patient is unlikely to survive the insult and reach to the hospital. However, there is usually, if the patient reaches to the hospital, what are the signs and symptoms that suggest the presence of airway disruption? Is the presence of the surgical emphysema, hemoptysis, and pneumothorax. Chest X-ray, in spite of the chest drainage, in spite of the addition of section, usually in that cases fail to re-inflate or to re-expand the lung, and persistent air leak may be present. In this case, the injury from direct trauma or as a result of high intratracheal pressure against closed epiglottis. So the mechanism of injury is either direct trauma by penetration injury, or blunt injury, or of intratracheal pressure. An increase in the tracheal pressure result in tear and rupture of one of the bronchi or sometimes the trachea. In that cases of tracheal injury, there will be hoarseness of the voice, dyspnea, surgical emphysema. The treatment is exploration and repair if possible. The diaphragm. Diaphragmatic injury or rupture result from high speed blunt abdominal trauma with the closed glottis. So when the patient is sustained a direct trauma to the abdomen, when his glottis is closed, so the pressure created inside the abdomen rise sufficiently to cause tear of the diaphragm, which is the weakest point of the abdominal wall, as you know, and usually the site affected commonly on the left side, because the right side mainly protected by the presence of the liver. So the left side is the weakest side when the intra-abdominal pressure rises enough to cause tear or rupture of the diaphragm. In that cases, the intra-abdominal content like the stomach, colon, can ascend or pushed inside the thoracic cavity, displacing the lung. Bowel sound can be heard in the affected chest, and chest radiography may reveal bowel gas in the lung field. A contrast study, barium meal or barium enema, can demonstrate that the presence of these structures, these viscera, stomach or colon, in the affected thoracic cavity. And occasionally the injury may be overlooked if the trauma is not severe enough, leading to major hemodynamic disturbances and the patient passed off, or sometimes the injury is overlooked even in the hospital. In that case, the patient can pass this accident or incident, and patient present later on with full picture of diaphragmatic hernia. Injury to the heart. Most of these injuries are to the heart and the major vessels or great vessels of the chest from blunt trauma are frequently fatal, and the patient rarely survive long enough to be seen in the hospital. Types of cardiac injury. Myocardial contusion, as we said or we discussed in the previous lecture, it is usually associated with sternal fracture, and any patient with sternal fracture should have high suspicion of myocardial contusion and should be monitored to exclude this injury. However, the true incidence is unknown. Myocardial damage usually gives rise to an ECG changes similar to that of myocardial infarction, and even with enzymes changes of the myocardial infarction. In severe cases of trauma, there may be arrhythmias and signs and symptoms of heart failure. Patient with an ECG changes and elevated cardiac enzymes should be monitored in high dependency unit with continuous ECG monitoring, and this area should be equipped with high facilities or good facilities for resuscitation for any complication that can happen, to be managed immediately. Chamber rupture. Chamber, the cardiac chamber, atrium or ventricles. This usually, as we described, the ventricle, if the ventricle is compressed between the sternum and the vertebral column at the time of the largest size of the ventricle, اللي هو at the time of the end diastole, before the systole beginning. Here the ventricle is filled with the blood with maximal size, and any compression to the ventricle or atria at that time might cause tear of the ventricle and cause rupture. And the chamber rupture is frequently fatal, and those patients rarely survive enough to be seen in the casualty. Treatment: if the patient survived to the hospital, the treatment other than thoracotomy and repair of the injury is required.